Good afternoon. I'd like to call the special meeting of the BOCC to address the emergency management related to COVID-19 and local state of emergency meeting to order. Will the clerk please call the roll?
Good afternoon. Miller?
Here.
Hagan?
Here.
Kemp?
Here.
Merman?
Here.
Overman?
Here.
Smith?
Here.
White?
Here.
County Administrator Wise?
Here.
Thank you. You have a quorum?
Thank you. We're now moving to public comment. The Board of County Commissioners welcomes comments from citizens about any issue or concern. Your opinions are valued in terms of providing input to the board. However, it is requested at the same time you address the board that comments are not directed personally against a board member, a staff member, or a representative, but rather directed at the issues. This provides a mutual respect between the board and the public. 20 minutes has been set aside for the public comment. Each speaker will have 2 minutes. Our first speaker is Jeffrey Kane.
Thank you. Calling in today as we need to understand what has happened to many U.S. citizens like you and me since March. Due to this constant daily barrage of an estimated 2.1 billion negative media messages on COVID-19 since March, it can create a psychological effect called confirmation bias, or simply brainwashing, used effectively in Nazi Germany and today in Russia and China. Messages about doom creates fear, and then it's used to control and get unquestionable compliance and acceptance to a position. So in Nazi Germany, how did the German population allow over 6 million Jews to be killed? The barrage of daily propaganda and fear of being caught and arrested for non-compliance by the Gestapo or even the citizens reporting on each other. But a democracy like ours requires all citizens to be constantly open-minded, not controlled by constant doom and gloom by the media who wants to hype COVID for ratings, but to say that my belief about our status on COVID is changeable and it's based on new information provided to understand what is truly going on now, and the truth will set you free. So let's check the current facts. So OSHA, the government agency for health and safety in the workplace, published during the swine flu outbreak in 2009 that cloth and even the best surgical masks are not created to stop infectious diseases like N95 masks are. Only dust, allergens, and blood spattering like would be in an operating room. So at best, they can only filter particles that are 0.6 microns or larger. But viruses like H1N1 and COVID are most only up to 0.3 microns in size, half the size. So OSHA warned about the negative health effects of masks causing dizziness, sleepiness, nausea, or even hypoxia due to oxygen deficiency. Thus, masks don't work and are harmful, especially to kids that have even smaller lung capacity. So are we open, again, to review the truth? Then we all said that we wanted to base decisions on facts as to when we can lift the COVID emergency. So COVID deaths and positive tests declining like they did.
Thank you, Mr. Kane. Your 2 minutes are up. Thank you, Mr. Kane. Your 2 minutes are up. Thank you. Our next speaker is Diana Klein.
Yes. Hi, good morning. Thank you. I'm calling on the Hillsborough County Commission Board to completely withdraw and rescind the local state of emergency order in Hillsborough County effective by 6 p.m. today and get our county completely back to normal business, because the recovery rate of infected individuals as shown on the board's dashboard is over 98.5%, which reveals that the coronavirus is nothing more than a common cold or flu infection. The stats prove there's absolutely zero justification for keeping the order in effect beyond this meeting, and no reason for people to live in fear of coronavirus or any other virus. Coronavirus and all other viruses are easily dismantled and destroyed by consuming foods and drinks that are rich in vitamin C, D, and zinc. These vitamins and the mineral zinc provide a person's immune system with the nutrients it needs to dismantle and kill any and all viruses, bad bacteria, and fungus, and prevent them from taking root in a person's body. Fermented foods and drinks are very rich in vitamin C. Fermented foods as well as bone broth are also very rich in prebiotics and probiotics that provide our bodies with a healthy gut of enzymes that also dismantles viruses, bad bacteria, and fungus. Some examples of fermented foods and drinks are pickles, olives, sauerkraut, raw apple cider vinegar, kombucha, kefir, and more. Foods rich in vitamin D include eggs, fish, particularly salmon, mushrooms, and more. Foods rich in zinc include garlic, peas, beans, pumpkin seeds, cashews, sunflower seeds, pecans, flax seeds, almonds, cocoa, and more. This should already be common knowledge in our society. Our bodies have a powerful immune system that are meant to fight off organisms that invade our bodies. Knowledge is power. Do more research and pass this information on to all your family and friends so everyone can remain healthy and free from the coronavirus and all other foreign organisms in Hillsborough County. For God has not given us a spirit of fear, but of power and of love and of a sound mind. 2 Timothy 1:7. Thank you.
Jason Kimball.
Wow, those first two public comments are phenomenal. So I just kind of want to expand on what the last one was talking about with normal. You can see just looking at the roadways, how big the stores are. The people are there. The people have decided that things should be back to normal. So it's that the commission is so upset with the population of Hillsborough. Ignore the voters at your detriment. It's not going to work. You continue to ignore the public comments, ignore especially those two public comments. So I know that on my, I inputted what I wanted to talk about, which again, I keep on bringing up this cloth mask study that indicates cloth masks, the infection that continue to that. And I also mentioned Alpha 1. I just want to point out that the origin of the mandatory mask order is based on experts who they don't know about peptide therapies. They don't even still today, after learning about it from calls to the EPD, they prescribe Alpha 1 in their treatment protocols. And I think it just very much discredits them significantly. And I also think that close attention needs to be paid to the cloth mask study. This is not something that's in dispute. I've never heard medical professionals dispute that cloth masks can significantly increase the risk of infection. So, guys, today I'd really like to see the cloth masks and to mention the risks of cloth masks and to explicitly say that cloth masks are not recommended and are certainly not required. And I'd ideally here and just not renew the emergency order at all. So that's my public comment. Thank you so much.
James Kennedy.
Hi, my name is James Kennedy. I'm the athletic director and president of the North Tampa Titans football and cheer organization. I'm calling in to speak to you guys today about our football crisis in Hillsborough County. This is the best numbers that I could come up with to let you guys know the amount of kids that are being affected. I've been doing this for 25 years, coaching and mentoring kids in Hillsborough County. I've did some numbers. We're looking at 55 organizations made up in the Tampa Bay area. We're talking about 40,000 football players and cheerleaders. Just speaking for my organization alone, just the initial investment this year to have a 2020 season, the kids spent $17,800 on shoulder pads and helmets, $15,000 on uniforms, which we've put a $7,500 deposit, non-refundable deposit down. We've paid insurance to insure our kids for $1,300. We've paid league dues to participate in a league of $1,000. That's a grand total of $27,600 non-refundable. If we're not able to go forward, that's a loss. I know we're not the only organization out there. Now, keep in mind, we're talking about 55 501c3 nonprofit corporations. You guys allowed baseball, softball, soccer, lacrosse to all go back. Lacrosse, I played it growing up. It's a contact sport. A lot of contact, not much different from football. So what I'm asking for you, we've been out there for 8 weeks. The last 3 weeks we've been in helmets. We're allowed to make contact with pads. I'm coming to you guys today to ask if you could see it in your hearts to allow us to put on shoulder pads so we can continue getting these kids acclimated to this heat that we have in Florida. It's a safety issue. You're talking about possibly letting us go October 3rd, which I think is way
Mr. Kennedy, thank you very much. Your time is up, sir. Thank you, Mr. Kennedy. Your time is up. Thank you. That was our last speaker. That closes the public comment. We now move into the emergency management update. Mr. Dudley.
Good afternoon.
Good afternoon.
All right. During this week operational period, we focused on community testing at our remote collection sites, Raymond James, Lee Davis, South Shore, Plant City, Brandon, Sun City Center, Waimama, Town and Country, and the University of Florida. This week, we're expected to hit our 100,000 COVID-19 coronavirus tests. We expect to hit that milestone, close the business today or tomorrow at one of our many collection sites, the 9 sites that we have here throughout the community. All of the test sites are still free for Hillsborough County residents to have a capacity for more appointments. We've seen a 19% decrease in demand since August 10th. This milestone comes 5 months after Hillsborough County stood up our COVID-19 test site on March 25th in the parking lot of Raymond James Stadium and began offering free testing. We want the public to know that these 9 sites and these resources are available. Residents can test close to their homes 6 days a week. Every day but Sunday, residents have access to free tests, a short drive, or sometimes even a short walk from their homes. There are at least 3 test sites available each day, and some days there are as many as 7 sites available for residents to take advantage of it. And we certainly encourage you to visit hcflgov.net/COVID testing to continue receiving free testing at one of our 9 sites. Also, Raymond James still offers antibody testing for the first 200 folks that visit the Raymond James site and request that testing during their visit there. The next available appointment is 27 August. We have plenty of tests available. At this time, there are no PPE challenges or logistics challenges or unmet need at this time. We have plenty of supplies to support our ongoing operations. Our community sites, we continue to see the transition back into our healthcare infrastructure. Our USF, our new USF team, they wanted me to let you know that testing site, it's been online for about a couple of weeks now, and they have plenty of capacity, plenty of appointments for folks in the USF area to take advantage of that testing. And we have 6 guests in our isolation site. I'll take any questions.
Thank you, Mr. Dudley. And I see no questions. Thank you very much for your report, sir.
Thank you, Mr. Chair.
Public health update, Dr. Holt.
Yes, Chairman. This is Dr. Doug Holt, Florida Department of Health. Today, we will review the epidemiologic hospital updated data for Hillsborough County. I'll provide my overview, and Mr. Wagner will then walk through the dashboard. During my segment, I will make some comments about where we are and somewhat about what's ahead. Special attention to testing and the data that we will be monitoring as we open schools. Get to the data, the graphs for children, they will be slightly different from what you'll see on the dashboard, but essentially it is the same data. And then we will conclude with 2 local physicians who will present on current COVID therapies, along with sampling of other studies that are being done as we learn more about this virus and how to best treat our patients. Kevin or Mr. Wagner, would you put up my first slide, please? Yeah, so we are making progress as we sort of move down the staircase here. We are now solidly within this orange zone that aligns with what the CDC terms the having sustained controlled COVID community transmission, given that our rate is 92 per 100,000 for the 7 days. Our daily positivity rate, as you'll see, is also continuing to decrease. 14-day is 7.27, with our 7-day around 6. As Mr. Dudley mentioned, we have noticed a decrease in testing, and I'll speak a little bit more about that later. The healthcare systems are operating essentially normally and have plenty of capacity. Next slide, please. This is a graph that shows where we were, sort of what's happened over the 2 months preceding, and then where we are. So if you look at the far right, here we are. We're in the middle of the yellow. This is still a relatively high level of COVID transmission in our community. And you can see back in June, around the phase 2 reopening, we had much less community spread at that time. So we continue to need the public to not relax their efforts. We must maintain these new habits so we can learn to live with this new normal, if you will, while COVID remains active in our community. This is really the most important thing that we can continue to do together in order we can keep our schools open, businesses seeing more and more customers that are coming back. So again, a reminder, it's a responsibility for all of us to avoid those 3 C's that we talk about: closed spaces, crowds, and close contact. Especially be cautious in areas that have small crowded venues, poor ventilation, or loud. We need to keep wearing our facial coverings when around others, and certainly when indoors. There may be disagreement about how masks work in labs, but there really is no disagreement that they work in the real world. Let's go to the next slide, please. Let's look at the Tampa Bay region as a whole. These are, again, our 7-day cases per 100,000. And as you'll see, about half of us, Holt, Hillsborough, and Manatee, are in the yellow, or in the orange zone, but heading towards the yellow. And yellow would be categorized as moderate to active transmission, but not sustained. Sarasota, Pinellas, and Pasco have already crossed that threshold. Our positivity rates overall, again, continue to decrease. Mr. Wagner, next slide. So this first slide is going to introduce what you'll see in a different format on the dashboard. The first is, well, actually, let me begin and make a comment. We were asked at the last meeting about checking with the hospital surge committee regarding their concerns about the care for pediatric in case there's a surge. At this time, our ICU availability pediatric in the region is 40%. In conversations we had with the hospitals, they feel that they are prepared at this time to handle any surge. So now let's look at the slide. This is a 7-day average of cases. So how many new cases are we averaging on a 7-day? And as you can see, collectively, with the red, it's about 30 cases a day. They're split About half of them are in the older 11 to 18 age group, and about 25% each in the elementary 5 to 10 and the preschool. Talking with our epidemiologists, these children that are testing positive are from symptomatic or close contacts within their families. Next, let's look at the next slide, please. This is essentially the same data, but we're looking at it again as our rate per 100,000 gives us an idea of comparable transmissions. As you can see, the younger 0 to 4 as reflected by the green line, and the elementary in the yellow 5 to 10 are below the overall community average, whereas the 11 to 18 are more approximate to where we are. With that, I'll make some comments about testing. It's gotten a lot of attention in the last day or so as the CDC has revised some of their guidelines. Would remind us that the CDC issues guidelines; they're not requirements. And as you look at these, the situation will determine to what degree that you would follow those guidelines, if you will. My first read on the new changes is I don't see things that are very significant. It's focused mostly on those about the need to test those that have been around exposed to a known contact. The Florida Department of Health and we locally have always informed the contacts of that option, but not emphasized it or directly encouraged it. The main benefit to testing contacts is that if you can get a rapid result, you can find an early case quickly and do the second round of testing, but that requires pretty much optimal testing situations. So for us, in most cases, we found that these exposures were in high households, and the results that we would get from them wasn't changing what we did. But on a bigger scale, moving forward, we need to evaluate our testing strategy, both who we are recommending for testing and access to testing. Back in April 27th, I outlined some things that we needed to go forward, and as it related to testing, we expanded our criteria to anyone who wanted one. So really consistent with the CDC, or not consistent with the CDC or Florida Department of Health. But since we had a lot of supply and little demand, and we also really didn't have any good idea of how much was out there, we expanded that criteria, and I certainly believe that was the right thing to do. We expanded our public access because at the time we were basically the only game in town because of the limited kits of PPE. Currently, we've seen increasing access through non-public sites. We're also seeing new technology, rapid PCRs and antigens. So over the next few months, we will need to begin to look at transitioning a little away from the predominantly public sites and embed this testing into the healthcare system. This is really where lab tests should be in part of the medical assessment. Not discounting that there will be other tests in the future that can be done by individuals at home, and I would hope so. Most of those would then generate a confirmation test from their provider. This is not going to happen now. We just opened schools, virus in the universities. So I am not advocating for any significant change, but we will need to begin to evolve over the next several months, engaging our healthcare communities on how we can help them and work with them to offer testing to their patients. With that, I'll turn it over to Mr. Wagner to walk us through the dashboard, please?
Yes, Commissioners. Kevin Wagner, Business Analyst, Healthcare Services Department of Hillsborough County. This is the weekly review of the publicly available dashboard. I will go over this in detail. Through today, the update around noon today, there are 36,354 confirmed cases of COVID-19 in Hillsborough County. A vast majority have recovered, nearly 27,195. And we have a 1.5% fatality rate of the total cases. As indicated by Dr. Holt, we are seeing a trend decrease in the average cases per day on the 7-day and 14-day at 186 and 211 each respectively. And we are seeing a decrease in the number of test results and reported in a weekly 2-week average of nearly 21,500. But on a positive note, the positive rate has been decreasing. Last week it was 8.26%. This week it's 7.27% on a 14-day average. As indicated by Dr. Holt, the hospital system on our TGH data exchange data that we have is operating at normal capacity with a generally percentage down on the census and occupancy for COVID-related cases. With regard to the cases per day, on the overall cases, we are averaging again 186 to 211. We showed this for a trending downward, as indicated by Dr. Holt on the previous slide. We are looking at the cases per day, and they are trending downward in an area that we want with regard to the key dates as presented. With regard to hospitalizations, as indicated before, we are still seeing the trend downward or flattening. On the hospital census, it's a 14-day average of 269. On the TGH data exchange that we're using, which is a subset of all the hospitals in the system, and the admissions are nearly flat on around 22 a day, on a 14-day average for the system. I'd like to speak on testing real quick. On the bottom chart on the far right-hand side, again, we are looking at the test results in weekly batches. The average is about 21,500 on a 2-week average. And we can see the last 2 weeks of where they are 22,000 and nearly 20,800. So again, we are seeing the decline in testing as indicated by Mr. Dudley and Dr. Holt. But the positivity is decreasing as well. This is new as requested by the commissioners and working with the school-age children as developed with FDOH and our IT data analytics team and staff. We are looking at the cases by school-age groups per day on this top bar. So on any given day, we see the number of cases for the age group. On July 24th, there were 65 in the 20 to 24 range, for example. So this is straight cases, which will have variability like the stock market, like Dr. Holt indicated, when we have spikes. But again, from a trending standpoint, we are seeing the trending downward from June 28th to August 23rd, that time frame. And we will always show the last 2 months. So again, on the daily cases by age group, we're looking at a downward trend. On the bottom, this is the 7-day per 100,000, the case total count. So again, looking from a trending standpoint, not the stock market variability, but looking at a trending standpoint on a 7-day, we can see where we were in June 28th, roughly 2 months ago, to where we are now by each age cohort per 100,000. So again, this aligns with Dr. Holt was saying earlier in his presentations on the daily. We're looking at a 7-day case total count per 100,000 by each age group. And this will be publicly available on our dashboard. And I'll stop there. Thank you.
Okay, Dr. Holt and Mr. Wagner, thank you very much for your presentation. Commissioner Overman, you recognize.
Thank you, Chair. I appreciate that. Can everybody hear me? I've got a new contraption. I just will make sure I'm heard. Thank you very much for your reports. I very much appreciate it. I took a look at the site, the Florida site last week, and I've noticed they've changed the way they report, I believe. Previously, they reported basically a 14-day number, which showed us at 219 on a 7-day average. But they showed last week that our pediatric positivity rate was around 11.2, something like that. This week, when I look at it, and I don't know if there's been a change in methodology because they don't really give you the time frame that they're looking at, whether it's a 7 or a 14-day. But this week they show that Hillsborough County has a 14.2% positivity rate in the pediatric report. So I'm trying to make sure that I'm seeing the numbers that you're showing us in our presentation and how they sync up so that we're comparing apples to apples. Can either of you, Dr. Holt or Mr. Wagner, help see how the reports have changed either at the state level or how we're reporting it and whether it's the same?
Yes, ma'am. The pediatric reports that have been generated or come out, I confess they seem to be a little fluid at times, the way they've modified and tried to find the metrics of the periods that they're looking at. The 14-day positivity rate is in that 14th percentile, while our 7-day, more recent, is a little lower, about 12%. I wish I could be more specific about both where the data comes from. I've been trying to get that to be better informed so I can inform you of that as well. These are all blended into our overall data. When we look at our overall positivity, they're lost in that large number. So,
And I appreciate that because, as I said, last week's report, a week ago today, the state reported a 14-day number and a positivity rate of 11.4. This week, they just report a 14.2 number, but they don't give you the time frame, whether that's a 7 or a 14-day number. It's just as of August 26th or yesterday. That was reported, I assume, yesterday morning. So, but in either way, whether it's, whether it's a 14 or a 17 day, the number has increased since last Thursday. So I didn't see that trend in the teeny tiny slide that I was looking at. So I'm just trying to make sure I can see what I'm looking for.
The slide we presented did not have positivity rates. It's just number of cases. Trying to get the data broken out by age group or the lab results we don't have access to that locally. We have made those requests across the state, and I believe they will evolve to get there as they have done in other examples. But right now, I don't have that the local breakdowns of positivity among those age groups that we're trying to present cases and rates. Again, the positivities for this small sample and they're under tested. This is not, the children do not typically get tested when they're asymptomatic. Majority of them have symptoms or are in a family where you would predict a higher percentile. So we need to do more testing to get a real comparable positivity rate for that segment of the population. And I'll stop there.
Thank you. I appreciate that. So if we don't have enough testing, and it sounds like we have plenty of capacity because our testing numbers have dropped, would it be reasonable to recommend that parents consider getting their children tested?
I think as I talked about, previously, I'm not in favor of asymptomatic testing. I think it's there was a period we were in in July, or actually June, where we needed more information. We had, and I think there was a lot of pent up interest for people to get curious and get tested. I personally would not recommend a parent to have their child tested if they're just for curiosity's sake. It would have to be for symptoms and a known contact, even though the CDC has said that's no longer necessary. If they have certain elderly or at-risk people in their household, I would definitely encourage that.
That would seem reasonable. I mean, but to ask a 6-year-old if they've been within 6 feet of someone in their class that tested positive, how long they were with them might be a little challenging to get the number. So it wouldn't be too unreasonable to suggest if they've been possibly exposed to ask them to get tested, correct?
Well, what we would, now you're talking about a classroom setting. As I get mentioned, most of these have been in households. So when we have a household or they go back to a household as a positive case, if they are in a high risk setting where they could be transmitting to vulnerable people, then if they were known close contact, then I think that would make sense. But testing everybody in a classroom or within that 6 feet, less than 6 feet for more than 15 minutes is not recommended at this time unless there are circumstances that, again, would alter what you would do. They're still going to be in quarantine. We say you can't test your way out of quarantine. If you are known contact, you will need to stay on quarantine for 14 days, irregardless of what your test is, negative that is. So,
excellent. Thank you very much. I appreciate your answers.
Dr. Holt, let me ask you, I'm going to piggyback on what Commissioner Overman said, just real quick. Did I understand you to say that the 14.2% is a 14-day positivity rate for pediatrics, and the 12% was a 7-day positivity rate?
The 14% was what is on is a 14-day. At least that's what my epidemiologist told me today.
Okay.
And he keeps saying it's changing, but then he gave me an interest. He said when he looks at it, he sees that there's a slight decrease in the last 7 days. So it's just local information that we have some access to that we can kind of get a little more real time than what's on the state sport, if you will.
All right, thank you. Commissioner Kemp, you recognize.
Thank you. I guess I'm going a little bit different. I thought it seems like a real game changer with the Yale University test now approved, with a saliva test that costs $5 and can get it back in 15 minutes, and that they are looking at producing Abbott Labs 50 million in a month by next month. And I'm just wondering, do we have any information? Because to me, that would be the kind of testing we need. We need, every kid in every school tested once a week or something like that until we know that this thing is tamped down to zero or as near zero as we can get. So I'm just wondering, do we have any information about the possibility of that? And I see it as we actually need to blow up our testing, especially when it's easy accessible like that.
Yeah, that technology that you're referring to is very appealing, and we've made some overtures to just find out more information. It's not available to us at this time, but with expanded ramping up, it may certainly come. And in a screening setting, using it repetitively for contained or populations, that does have certainly some value, depending particularly on the level of your community-based transmission. So I would concur to you, if we had that tool available, a saliva much versus a nasal swab, you get more rapid testing, then certainly would need to reassess the use of that testing in work setting, university settings, school settings. It's a variety of different aspects. And as you said, it really sort of changes everything. But based on what we have right now, that's where I'm making my recommendations.
Right. I just wanted to say that because I think it is a huge game changer, and they apparently are saying that they can get 50 million, tests out in a month, and they said the whole U.S. had like 20 million tests done in a month. So, if we could do that, that would. I just think that would be incredible. I'm encouraged by the drop for the state of Florida as well as Hillsborough County, going down from high numbers of rolling 7-day average for the state up somewhere near 11 or 12,000 to now like 3,200. And so that's a great encouragement. And I think, we can, I think it can only be attributed to not even a mask order, but to people being really willing and seeing how serious this is and seeing what an effective tool that masks are. So I'm very appreciative of the public, whether it's under order or otherwise, that they're heeding, I think, greatly. You can see it in the numbers to the fact that, as you say, the 3 C's, don't go into the closed spaces, the indoor spaces, don't be with the crowds, and the close contact, and wear a mask whenever you have to be, or that's something that's necessary. I will say I do expect that we're going to, most unfortunately, we're going to see a spike. I cannot imagine, I'll say it right now, with schools opening even at partial capacity. And I'm very sorry about that because, the numbers that, again, I think it's worth pointing out. We had, as you said, 8.26 or was said 8.26 positivity rate the week before. Now it's 7.27. Again, great. That's wonderful with, pretty much the same number of tests. That's a great decrease. But as has been stated here many times before, the World Health Organization, the CDC, and everyone says that before we open schools, we should be below 5%, perhaps 3%. So I think it's very dangerous under these conditions. And I unfortunately think that that's going to put community spread again at our doorstep. So I guess we'll just have to watch for that. But the one thing that I see really, really hopeful is this effective, cheap, widespread saliva, fast tests that could be done. So I think that would be a wonderful tool. And I'm hoping that we can get that in to help us coming up, because I do see that this is going to have a bad impact on us.
Okay, we're going to move on to our next presentation. Dr. Douglas Ross, Chief Medical Officer, Advent Health-Tampa. Good afternoon, sir.
Good afternoon, Mr. Chairman. I want to thank the commissioners for inviting me to speak today on COVID treatments. I am the Chief Medical Officer of Advent Health-Tampa, and I'd like to just sort of go over what I'm going to speak about today. We're going to talk a little bit about keeping non-COVID patients safe, what we do in our hospital and other hospitals throughout the country. Talk a little bit about testing, and I know you all spoken about testing already, but we'll just comment a little bit more about that. Talk about convalescent plasma, obviously much popularized in the press and by the president this past week. We'll talk about remdesivir, the use of dexamethasone, steroid, and then, how to avoid, and you've already spoken about it a little bit, getting COVID, or how we can continue to work on flattening the curve and what that really means. move forward. At Advent Health, and really this is true throughout all hospitals now. First of all, we cohort our COVID patients into a specific units so that the patients who don't have COVID are not exposed to COVID within the organizations. We maintain social distancing as everyone's doing now, but even in the cafeteria or doctors' lounges, nurses, areas, all our social distancing. We've limited meetings as much as possible to small groups. And if not, we do it virtually like you're doing today for this meeting. We also check temperatures at our door. We have just this week standing up kiosk temperature devices. These are supposed to be even more precise than the handheld ones you're used to seeing on the lay press. In terms of monitoring people for temperature before they get into our facility. We've obviously limited visitation. We've also asked that both our team members, our employees, as well as patients wear masks. So everyone inside the organization are wearing masks. And then we're very good. We've been good before, but we're even better now at keeping everything clean. To access particularly touch areas of frequent touching, like elevator buttons, door handles, etc., are cleaned repeatedly. And as you know, we use a mild Clorox type of sanitization, but soap and water has been shown to be equally effective against the COVID virus. In terms of, and by the way, please stop me if you have any questions or for me, it's informal. I know this is a formal environment, but in terms of testing, all of our facilities have a company called Cepheid. I have no financial interest, nor does Advent Health have a financial interest, only to say that, and talk a little bit about testing. This is using a nasopharyngeal swab, and as you probably know from either friends, relatives, or self, in terms of having had one of these tests, you don't, it hasn't been done right unless you feel it sort of scraping a little bit of the base of your brain and giving you a little teary-eyed. It is a far back place you need to swab in order to get an accurate reading. This test takes only about 45 minutes to run, and it detects parts E and N proteins of the virus. And you can see, and I don't know if you can see my pointer, but you can see on the right-hand side, I provided a diagram of the virus in a variety of different parts. And as you can see, there are spike glycoproteins. That's the tree-like structures coming out of the virus membrane. And then you can see marked M proteins, E proteins, and inside the virus are N proteins. So in fact, when you get a study back or positivity, you're getting a positivity on a fragment of the virus. So in other words, you don't know whether that virus is intact or it has actually been broken up by the immune system. But it picks up those portions of the virus and gives you a positive result. You have to have a certain minimum amount of viral load in order to get positivity in a test, and you can see that there. We are also ramping up several different other types of testing within our organization, and we have also used the commercial laboratories outside as well as all the other organizations do. We also are doing some testing of a saliva test as well. This is not the Yale test that was spoken about earlier, but this is a test created by a local company, which is quite exciting in the Tampa Bay area, that also does a testing within 15-minute results. And the challenges have been around testing, and you probably know this, the commissioners do, in getting reagents and having reagents available. We've been pretty good about having enough reagents to test our patients, but obviously it's always it's still a little bit of a challenge. Let's talk about convalescent plasma. and just talk a little bit about how it works. So in patients who've had COVID, they have built up an immune response, which are really antibodies. And there are other types of immune response, but particularly for the plasma therapy, we're looking at antibodies that will be directed towards the virus. And so we've been able to, and I mean we as a population, have been able to get people who have had COVID to be very willing donors to donate their blood for this plasma therapy. And in fact, yesterday I consulted with our blood bank, and although the blood companies tell me that there's a significantly increased demand, something on the order of 500% over the last month in convalescent plasma requests, they are still able to handle the load. And that's really because people are paying it forward, so to speak, that they're willing to donate their plasma for this use. The plasma is spun down, so all the white cells and red cells are removed. Oftentimes they are given back to the patient. Sometimes they're not. But you're left with plasma, which is clear, well, yellowish fluid, which contains proteins and antibodies that are actually then given to patients. And that will actually, those antibodies will be used by the person receiving them to fight the infection, because those antibodies will provide access for one's own immune system to identify the virus and fight against it. And so, so that's really in essence how this all works. So controversy abounds, but what we have seen is that we have seen improvement in our patients at Advent Health-Tampa by using convalescent plasma. And, you know, the studies that have been touted out there really are not blinded, et cetera, and that research will come. But what has been shown is what's important is the amount of antibodies within the plasma given, as well as what time in the progression of the disease actually the plasma is given. And so it's been shown if you give plasma 3 days, within 3 days of symptoms, if you are requiring hospitalization, because this really is not something we give mild or moderate, but if you require hospitalization and you get plasma, 3 days, you actually see a decreased length of stay or a shorter time to recovery. And that's obviously very good. And in the slide next to the right, you see that before plasma, the person's oxygenation, meaning how much the percent oxygen their blood is carrying, is 93% of the capacity. It improves to 96% after plasma. On this little pictures on the left, it tells you that 5 patients required mechanical ventilation before treatment. 3 out of 5 recovered enough to breathe without one after the treatment, as well as got discharged 3 out of 5 again, and had a decrease in their symptoms overall. So although controversial in terms of the science, we do find it a useful tool in treating patients and with faster recovery. In terms of the data that's out there, just to clarify a little bit, the Mayo Clinic has had a study ongoing, and that's how we got our plasma up until this really past week, you know, the weekend before last, I guess, or this past weekend. We had this, the Mayo Clinic had about 35,000 patients transfused with plasma. And the problem is that they had really no blinded aspect of it. So there was no control group, no blinded, whether you knew it or didn't, whether they were getting the treatment or they weren't getting the treatment. And also each hospital actually sort of gave plasma in different, for different indications in terms of how severe the patients were. And so that work is ongoing, and I'm sure out of that 35,000, we're going to see some very interesting data anyway coming out. And also the Houston Methodist research, which tried to match control group, which then did have a control area. But basically, when you're looking at all the patients transfused with plasma, they benefited if transfused early versus later on in the course, and with higher titers of plasma, higher antibody titers in the plasma. Now, let me explain to the commissioners, and you probably know, there are two phases of this disease process. The first phase is the viral phase, and that's when the virus itself multiplies significantly in the body, infects cells, damages cells, and really just continues to grow. During that phase, you would expect helping the immune system with antibodies, for example, would help fight off the infection. And so this is why plasma is thought to be used earlier will help. So in fact, using it later doesn't help because the second phase of the disease is in the inflammatory phase. And the inflammatory phase, we don't completely understand. We think it's some sort of autoimmune response that's being created, or it's been hypothesized. I can't say it's known for sure that it's an autoimmune response. And that phase requires tremendous inflammation, but the body is actually fighting against itself, basically. And so if you use these kind of treatments in that phase, it won't help because the body is attacking itself. And I'll talk to where steroids come into play in a moment. I'm going to talk about remdesivir now as well. You've heard about remdesivir. Remdesivir was originally developed as an antiviral. It was thought to help during SARS and other infections, as well as Ebola. It never played out to be an effective anti-Ebola drug, but it has shown to be effective in SARS-type viruses in animals, and we've been seeing some significant changes in patients using remdesivir as well. The study that's the most impactful of remdesivir was based on 1,000+ patients. It was a blinded study looking at whether remdesivir helped. I'll get to that in a minute, but just to say that what remdesivir does is it actually affects the ability for the virus to replicate. And so it stops the replication of the virus. The virus actually needs to get into human cells or other animal cells in order to use some of the parts of those cells to reproduce. And with the drug in place, some components are substituted by the drug into the virus replication or multiplication, and that stops the ability for the replication to occur, and for the virus to continue to spread. And so we have been also using remdesivir, and the study that I reference really talks to about 1,000 patients, and it was shown that it was most useful when a patient was hospitalized requiring low flow oxygen, what we call 2 liters of oxygen per minute, applied usually into the nose through those tiny tubes that you've seen on TV or visiting patients in the hospital. High flow oxygen or patients on ventilators, where they just didn't have enough patients to actually say whether or not remdesivir helped. As a matter of fact, with the small numbers, it didn't seem to help those patients. But if you give the patients who are mildly requiring oxygen, it seems to help. And of course, earlier on in the disease, it helps more, again, because that's during the viral phase of the disease and not during the inflammatory phase. And so we normally give remdesivir for 5 days, as that particular study showed that was the length of time that it was needed for the drug to be effective. And we have seen a decrease in terms of the time it takes for patients to recover, and which is exciting as well. And we use it either by itself or in conjunction with plasma, depending on the condition of the patient. The last drug I want to talk about, or treatment I want to talk about, is dexamethasone. Again, in severe cases, the body's immune system, we think, overreacts to the virus and really mounts an attack, causing excessive inflammation and potentially some autoimmune component, causing tremendous inflammation in the lungs and the heart, etc. And dexamethasone is a very cheap, very accessible drug, antifungal drug that's a steroid that really affects the immune system by suppressing part of the immune system and decreases the effect of that inflammation phase. And we use it now quite frequently, pretty much on all patients who have entered into that, what we think is the inflammatory phase. They start on dexamethasone in order to prevent them from having that immune system cause such a severe inflammation that the lungs are irreparable, or other organs, and you succumb from the disease. So now I just want to address how to avoid COVID, and that's been touched upon earlier on in the meeting. But of course, I firmly believe that what you need to do is have social distancing, 6 feet at least. In fact, a sneeze can be shown to be greater than 6 feet. Covering your nose when you sneeze or blow or cough, either with a tissue or, as you've seen, with the crook of your elbow, to prevent the spread. Wearing masks, and I know we've heard controversy, but there are some studies, and one particular out of the University of Michigan, that actually tested flu. And during flu season, and this was a controlled study, there were patients who wore masks, or I shouldn't say patients, but subjects were wearing masks, and those that weren't wearing masks. And in fact, there was a 75% decrease in the patients or subjects that were wearing masks in the spread of flu. And so masks, they don't. And to the caller, to the comment earlier on, I would just say that yes, she was so I think it was a she who actually correct in terms of the size of the virus versus the size of the porousness of a cloth mask. But really, where these what it's thought to be, how it's supposed to have helped, is in fact the virus is actually aerosolized on a water droplet or a mucus droplet from your mouth or nose, and those are bigger, and so those get caught on the mask and actually don't go through. So the virus does sit on the mask, but it doesn't get through. Again, I'm just speaking to the science of things. Again, you don't want to touch your eyes or nose. And I didn't point out that when you do cough or sneeze and you do use a tissue, please wash your hands right after it. And I'm not just remembering what my mother used to say to me, but in fact, obviously soap and water has been shown to be very effective in taking care of the virus. And then, of course, you might have virus on your hands, so try not to touch your eyes, nose, or mouth. And you should clean frequently touched areas. Stay home when you're sick, even if you just have the slight inkling of being sick. And I talked about washing your hands often. The best action is really sheltering in place, and I know that that's a thorny subject, and I'm not advocating that at this point, particularly now that we are really very much flattening the curve. And as you can see, that some studies have showed that canceling of events and meetings has slowed the transmission in some communities by 35%, which is pretty significant, although obviously it's paid a very significant toll on society. And this slide I like a lot. It's an animation. It'll take a few times to pass through to understand it. But these are how the disease spreads, obviously. If you look at the different lines, one person has the disease, it contacts 3 others, it contacts, et cetera, and so on. But if, for example, that person works from home or doesn't go to a barbecue or didn't fly or stayed at home, then you sort of cut out that node, that infectious node, and you decrease. And I think really that's what you've seen and what we've been fortunate enough to see in the Tampa Bay area as well as in Florida is those strategies being effective in blunting the curve. And I should say, I do like the conversation about blunting the curve, but I also would like to say to you that you really don't, there's a lot of data that's coming out around, people who actually suffer long-term from the effects of COVID in people who are mild and moderate. And so really, if you can avoid getting COVID, that's the best strategy overall until we have an immunization. And I'll stop there. Be happy to answer any questions.
Dr. Ross, thank you very much for that in-depth presentation. We truly appreciate it. Commissioner Stacy White has a question. Commissioner White, you recognize.
Thank you, Mr. Chairman. And I don't have any questions, just comments. I do want to start by thanking Dr. Ross for an excellent presentation.
Thank you, sir.
The Trump administration has worked closely with the FDA to fast-track convalescent plasma as a safe, potentially life-saving treatment. As a healthcare professional, I completely understand that the randomized, double-blind, placebo-controlled clinical trial is the foundation of modern medicine in the United States. At the same time, I recognize that this pandemic is no ordinary situation. In fact, the concept of fast-tracking potentially life-saving treatments with promising safety and efficacy data is not a new concept. I'm confident that the availability of this treatment will improve outcomes and save lives, and I encourage all who have contracted COVID-19 and recovered from it to donate plasma at a local blood bank. I'm also encouraged by the data on the antiviral medication Remdesivir, and I'm thankful that it's been made available in our community. Thank you, Mr. Chairman.
Thank you, Commissioner White. I don't see any other hands or questions at this time. Dr. Ross, thank you so very much, sir. We appreciate you taking the time to come before us today to make that presentation. Thank you so very, very much.
Thank you, Mr. Chairman. Appreciate it.
Okay. Next, we have a COVID-19 research study by John F. Toney, Dr. Toney. He's the professor of medicine, division of infectious disease at the University of South Florida, Morsani College of Medicine. Dr. Toney.
Good afternoon. My purpose here today is not necessarily to talk about ongoing research, because that does vary around throughout the community. There are a wide variety of things that have been ongoing and things that you will see appearing over the next few months. There's a lot of things going on, as you probably know, around the state. There are some COVID vaccine trials that are just starting up in Orlando and in Miami, and most likely in our area. There are a wide variety of investigational treatment things that are ongoing, and there are more to come. Many of the hospitals, as you've already heard, have been using convalescent plasma. What I can bring to you today is to tell you about my family's journey in getting COVID. It was completely unexpected. It came from the community. Did not come from me working in hospital. It came because my daughter had a friend who grew up in Terre Haute, Indiana, and was going to go back and see friends as they do annually. So this is early in March. He went up, spent a week there with his friends. They went around and did a wide variety of things. And on the way back, complained about how really tired that he was. So she picked him up. He lives in Lakeland, drove him back to Lakeland in her car, and the next day he started having fever and a cough. Later on, he lost his sense of smell, and fortunately did not have a severe case. He was never tested, doesn't have health insurance. My daughter ended up starting to get a cough. We got concerned. Tried to quarantine her in the house the best that we could, but by that time, that as things go along, the other two people in the house, myself and my wife, had already been exposed. My daughter ended up over the course of a little bit more than a week getting pretty severe. And the night before that I decided that she really needs to be evaluated in the emergency department, I started having symptoms. So she was admitted, and this is not an advertisement, but we did go to Advent Health-Tampa because this is relatively close to us. Could have been to any hospital in town. She was admitted, I was tested, and sent home because I really wasn't symptomatic. After trying to manage my own infection at home, after a week, and after some of the early things that were recommended to try, which in my case didn't really help, I know what can happen. I know that as you go along and your oxygen concentration in your lungs go down, you can rapidly become ill. My daughter is 35. I'm 65. And my wife is a little bit older than I am. She's 66. We have, with an N of 3, the number of 3 in our family, my wife, which took quite a while to get her tested because she was totally asymptomatic. I was pretty symptomatic. I was in the hospital for a week and did okay, fortunately. My daughter was in the hospital for 1 day short of a month and on a ventilator for almost 3 weeks. So in one family, you can see the whole spectrum of illness. It's very concerning, and the toll it takes on family members is really a huge issue for many people, as you well know, especially nursing home individuals, where that if they have someone in a nursing home that they can't go see, they get ill, they can't see them in the hospital, and they may die without ever seeing a family member. And as you know, as time has gone along, hospitals have tried to accommodate for that the best that we can. It is not the flu. It is more than just a pneumonia for many people. When I was a medical resident, I came here in 1981, excuse me, to do my residency. I ended up getting pneumococcal pneumonia because I was totally exhausted and had it and was out for about a month and lost 10 pounds. I recovered from that and never had a problem with it again. And I make sure I don't because I get vaccinated to prevent it. This was 10 times worse than that. The amount of complications from that just with me are profound fatigue, which is now much better as time has gone along because I'm doing things to try and make myself better. The breathing issues, fortunately, I did not have to go home on oxygen, but just pushing yourself to go out and exercise to get yourself hopefully back to where you can is challenging. One other issue that hadn't really been discussed, but it's an ongoing treatment issue for many patients that we see who do get really sick with this, is the clotting issues. We've never had this with any of the other coronaviruses that circulate around that give us, you know, common cold. This is a completely different animal. It acts differently, and a lot of it that you've already heard, we don't clearly understand yet. We've seen children who end up getting, you know, this multi-system disease. We see some people having some dermatologic changes. We see people, young people, having strokes because of this. So there's a lot of this that we clearly don't understand. We do know that there are some people who don't get very ill or, you know, pre-symptomatic or asymptomatic who are pretty efficient at shedding this. So those are the people that we need to understand better, and those are the ones, as you heard discussed earlier, that if we can get people to wear masks, so if they're spreading things, but you keep it contained within a mask and they're not exposing other people, and if you can get them to wear a mask, and then if you can get them to stay a little bit apart, as we talked about, the chance of them getting infected becomes very small, not impossible, but much smaller than if both people are not wearing masks and are close together. It is a conundrum for us because recommendations have changed when we learn more about these things, and they'll probably still continue to change. I'll also point out for you that, remember, it was in 2009 when we had a new strain of influenza that didn't come out of the usual places around the world. Usually comes out of Asia, and then goes around the world and to North and South American, the Northern Hemisphere and Southern Hemisphere. But this one was different. In 2009, it was April of that year, not towards the winter for us, came out of Mexico and became a pandemic. It was a completely different H1N1 strain. That strain still circulates, and actually, it's part of influenza vaccine because it's still around. But we do have a vaccine for that, and the vaccines are very helpful in either keeping you from getting infected, or if you do get infected despite the vaccine, of making it a milder disease. We're not there yet with vaccines. Vaccines are coming. I think they're going to be extremely interesting. They're not all the same. Some use different mechanisms to try and protect us, and it's going to be, because I'm an infectious disease person, exciting to see how well they work. If some work better than others, excuse me, throat's drying out. Then we'll need to understand why that happens. There's a lot of the immune system with this that we don't clearly understand, and you're probably going to see recommendations change. We did learn from influenza, as all of you know, and I know you've seen this on the media, no matter where it was, going back to 1918, and the recommendation to wear masks, and people didn't like it. And there were the same groups of people that went out, they refused to wear masks and everything else. But we didn't have really good vaccines at that point in time. It's a little bit different now, but now we're in a different disease that we don't understand. And it was very similar to 1918. So I think, just trying to do what you can to protect yourself. And nobody likes wearing the mask if they don't have to. Excuse me. We're social people. We like seeing other people's faces. We like being around other individuals. And now we're basically telling people that puts you at risk and you shouldn't do that. But after a period of time, everyone gets tired of doing that. We want to go back to normal. If we can do that, if we can get these rates down extremely low and we can slowly start opening things up and people remain committed to doing that, knowing some probably won't, then maybe we can start moving back into the economy that we had and back to the intrasocial actions that we've had in the past. But it's going to take time. But that's what I wanted to bring to the table was I know what it's like. And I can tell you, if I had a choice, I would never get it. The day I got admitted to the hospital, I wasn't sure if I was going to live or not. Excuse me. Sorry, I should have brought some water. I do have a neighbor who also had COVID, and he's not doing so well. He isn't on oxygen at home, and he's going to have a long recovery. The other thing we don't know with people is there going to be some kind of post-COVID issues that will show up later? Will it be an autoimmune disease? Will we see something, although I'm thinking probably not, but you never know, like a post-polio syndrome that some people do get? We're really early into this pandemic with something that's completely different than what we're used to. So a lot of this we're going to see. A lot of the data that you're going to see with the treatments really does need to be done through randomized clinical trials, and that's why Mayo is actually going to do their RCT with plasma. I donated plasma as well. We need to give it earlier, as you heard discussed. We need to see about getting it titer and giving higher titer if we can do that. We also need to see in people, we know that people that get really sick tend to get higher antibody titers, and people that have mild disease maybe don't, and maybe their antibody doesn't last as long. So you may have been hearing about some of the other things of using monoclonal antibody to go after this virus as well. One of the things that you can do is to then compare monoclonal antibody to plasma. Plasma is shown to be very effective in managing this. You're going to see new tools coming out. I can't tell you how many different products that I have seen that want me to do trials. I probably wouldn't sleep at night if I was involved in all these trials. But there's a lot of things that we're looking forward to having more tools to treat this with. My analogy is I'm old enough to remember HIV. I was here right as it started. And the first drug that we had that came out that we called 3 letters, AZT. Now it's Cydoviadine. AZT was a great drug. because we had nothing. So compared to nothing, it was a great drug, but it had really significant limitations. The virus mutated a lot, and the drug only worked in most people for maybe, if you were lucky, 2 years before the resistance mutations caused it not to work. But it was something that could push back the infection until we had other better drugs. And I think that's kind of where we are with remdesivir at this point. Excuse me. It does have activity. It is certainly better than not giving anything, and we're learning better how to use it. When I was in the hospital, the only way I could have gotten remdesivir is if I was under 18 or pregnant, and I didn't fit either one of those categories. So it is very interesting. We're finding out more things to give. We're learning more about how that this virus is spread, and we're learning more about how it got spread around the world and what are some of the resistance genes going around that have apparently made it even easier for itself to spread, but not reduced the pathogenicity of it. It still causes nasty disease, even though now it seems like it can spread a little easier. So that's where we are. And you've heard a great discussion about where we are. Our rates are coming down. Our mortality is coming down. Hospitalizations are down, which is great for, healthcare workers, because a lot of us are pretty tired. But that's where we need to keep focused on this. We need to try and keep people engaged, try and get them to protect themselves. And if you think about it, it's not uncommon or not an unreasonable thing to talk about trying to protect yourself from a sexually transmitted infection, because if you don't do it, who is? So I'll stop with my comments. If you have questions, I'd be happy to try and answer them for you.
Dr. Toney, thank you very much for that presentation, and we're so glad that you and your family are doing a lot better. Very glad to hear that, so thank you very much. We do have some questions from some commissioners. Commissioner Kemp, you're recognized.
Thank you. I just wanted to thank you too very much for this presentation. I think it was very important for us to hear your story. So I appreciate you sharing your personal story. I think too often, first of all, we're looking at deaths, which as enormous as they are in the state of Florida, and in Hillsborough County, over 500 people have died of this, over 10,000, I think over 11,000 maybe now in the state of Florida. And I think people just, I can't even believe that I hear people, first of all, just stating the deaths and then sometimes almost dismissing it as if, oh, it's just people that are older, which I find very concerning. But as if that is the only category to be concerned about. People, I appreciate you distinguishing this from the flu. I've known several people who have had this, and they have gotten deathly ill, and several of them thought they were going to die, and thank God they've survived it. There's a few others that I'm not so sure about, but I appreciate your personal story. One thing you did point out too, which I think is very important, is that we don't know the long-term effects of this infection. So that once someone, these children, adults, anyone contracts it, we don't know what this will mean in the future. And we, as you stated, have many evidence of other kinds of viral infections or disease that pop up on us later, and it's not uncommon. The chickenpox and and shingles, things like that we don't understand the effects of those. So I appreciate you pointing out this, because I just think there's been, I can hardly believe it, too cavalier an attitude, and the fact that there's something as uncomfortable as it might be, it's very minor to do something like wear a mask. And some of this stuff can be a little tough, but it sure is way better than having this spread be as it has been. And I'm glad we're containing it, but I think you're sharing that story is really important. So I appreciate it and thank you very much. And you've given us a lot of food for thought for the future as well, and what we could be facing.
Thank you.
Commissioner Overman, you recognize.
Thank you, Chair, and thank you, Dr. Toney, for coming and telling us your story and helping those that have not experienced it before have some understanding and in a more public way. I have heard many of your stories very similar to yours, and I have lots of folks that I have either known infected or actually passed away as a consequence of this disease, and it is serious, and it is something we don't know about. I have some curiosity. Up until the 18th of August, we did not, or we're not reporting very many children in the state of Florida passing away, but since then, the state's reporting 8 children that have passed away, one of which I believe is either here in Hillsborough or over in Pinellas, I'm not really sure. But we're starting to see that children, even though they have been reported not as impacted, and if they're your child, you're impacted. So I think it's important for us to understand the predispositions or certain factors or any research that we understand that suggests that someone may be more or less at risk. I mean, we've heard older individuals and those with hypertension or high blood pressure or any kind of organ disease or organ transplants. But are there other factors that you're aware of with your experience as an infectious disease physician that you could share with us that people may want to take extra caution if they're out and about because they may or may not know they're at risk?
Well, I think that we've heard a lot about people who have, other medical issues, comorbidities. And if you have underlying lung disease, COPD, asthma, etc., you have underlying heart disease, you have, high blood pressure, maybe some of the medication could make it easier for this virus to cause problems in your lungs. Although there's other data that says, no, maybe it helps protect. So that's not really clear. We know that there are a lot of people who do have heart problems because of this, because many viral infections can cause inflammation in your heart. The name that we would call it is, a cardiomyopathy. And not uncommonly, that happens after viral infections. So, I know that there is a healthcare provider who I had a discussion with who actually has a viral myocarditis from COVID. And so, is that going to be something that, over time heals itself, or is it going to be something he gets to deal with for the rest of his life? I don't think we know that yet. I mean, there's just huge unknowns. The other thing is, everybody says, well, I also heard a friend of mine, who was kidding. He said, no, let's just all go get it and get it over with. And I said, but the problem is, as you've mentioned, we don't have a good way of knowing who's going to get severe disease and who doesn't. You probably have seen, because they've been in the media as well, relatively young persons, some were bodybuilders, no medical conditions, who get this and have severe disease. And this is a very hypermetabolic disease to get. What do I mean by that? It takes a lot of energy in your body to fight it off. In 2 weeks that I had this, a week staying at the house and a week in the hospital, I lost 20 pounds. I would not recommend that as a weight loss reduction program.
Right.
My daughter lost 40. So, that means you're losing muscle mass, and that takes longer to put back on. I'm older, so it's taken me a while to get some of what I lost back. And I think that's the thing that people don't understand, because that's all they hear is, well, young people, they get it and they do fine. Well, my daughter's friend did. I can also tell you that I've had some physicians confide in me and some other people that, I think I may have had it because I lost my sense of smell and everything. I felt really bad for like a week or so, but I didn't get really ill, and they never got tested. Did they give it to somebody else? I don't know. They don't know. And fortunately, they did fine. So that's where we get into this huge conundrum of, we thought it'd be great to test everybody, but the lag of getting those results back make that not that helpful. Trying to do other tests that could be a point of care test so that you're right where the person is, they do the test and you get a result back relatively quickly would be great. And I think you're going to see them. But, you know, with the first rush to get these out, some of them just did not perform well. They didn't have good precision. And that's what we really need is a very reliable test. If we get reliable tests that can function very quickly, that would help us.
Thank you very much.
Yeah.
Commissioner Smith, do you recognize?
Thank you. And I also want to thank you, Dr. Toney, for sharing a personal story from your professional experience. It's great that we every week get these facts and figures and data points and graphs, but they don't tell the whole story that is told when you have the lived experience of this disease and understand. And it was interesting that your family had a wide range of experiences with this disease. But I can add a story that provides a fuller piece of the spectrum. I have a very close family friend that I'm godmother of his daughters, who just passed away of COVID in the last week. And he got the best treatment we can have in Tampa Bay, went to ICU in a local hospital after being treated by doctors, and he got remdesivir. And he got plasma, convalescent plasma. He got oxygen, and he got put on a ventilator for over 3 weeks. Before he passed. But I had, because I've been my husband and I are godparents of his children. We were old family friends for 35 years. We had a ringside seat to the daily reports with the family of the heartbreaking horror that that end of the spectrum of this disease goes through and what their family goes through. And having a ventilator is a torturous experience, and what the body has to go through in the hospital with that is horrific. So I share this because I think it really is important to when we're talking about this disease to get beyond the numbers and the only 1.5% fatality, you know, and the experiences of other people in the community who haven't yet been touched by this disease, so that hopefully we can share the importance of everybody pitching in our community to try to work as hard as we can to keep this devastation from other families. And so I thank you very much for being willing to share your experience and help us see that real lived picture from your professional experience. Thank you very much.
Thank you.
Commissioner Kemp, did you have another question? Dr. Toney, thank you very much, sir. We appreciate it. Stay safe, okay?
Thank you for your time. All of you, please stay safe.
Will do, sir. Try our very best. County Attorney update, Ms. Beck.
Yes, good afternoon, Chairman Miller and board members. We have provided a draft order extending the local state of emergency in accordance with Florida law for an additional 7 days, and that is part of your backup. And at this time, it would be appropriate to entertain a motion to consider that draft order.
Move approval.
Motion by Commissioner Overman, second by Commissioner Kemp to extend the emergency order. Is there any questions? Seeing none, please call the roll on the motion.
Miller,
Yes.
Hagan,
Yes.
Kemp,
Yes.
Merman,
Yes.
Overman,
Yes.
Smith,
Yes.
White, Commissioner White,
Probably on mute.
He's there, but we're not hearing him.
Yeah.
He's on mute for sure.
Yeah.
He
Move on,
must
sir. Move
away
on, sir.
from the-
okay, motion carried 6-0.
Okay. Anything else, Ms. Beck?
No, sir.
Okay, thank you. Is there any other discussion the board wants to bring forth today?
No, sir.
Anything else? Anything else going once? Anything else going twice? Anything else going 3 times? Okay, we thank you for being on here. Board members, we'll see you again at 6 o'clock tonight.
Yep.
In the meantime, between those hours, be safe. See you then.
Thank
Take care.
you.
Thanks.
Thanks, everyone.